So let me start it as, what is CPR? So it's a series of life-saving actions that improve the chance of survival following the cardiac arrest. Cardiac arrest results from the failure of pumping action of the heart or circulation, which may result in loss of consciousness and absence of pulse and breathing. So there's always a chain of survival in CPR. So what is this chain of survival? It can be, I've just made it in two different according to the American Heart Association: in hospital chain of cardiac arrest and out of hospital cardiac arrest. So in hospital chain of survival, in hospital cardiac arrest chain of survival would be recognition and prevention. After recognition, immediately activation of the emergency response. There are different numbers in different institutes. It's an activation of the code blue. So if after that, immediately after the activation, you have high quality CPR, defibrillation if those are shockable rhythms, as soon as possible, and effective advanced life care support, and then integrated post-cardiac arrest care. And out of hospital, it is activation of the response. It's high quality CPR, AED or defibrillation if available, then advanced resuscitation, shift the patient to the advanced resuscitation, and post-cardiac arrest and recovery. So we have to know this chain of survival. If going for the theory, this is a commonly asked question, as well as in practical scenario also. These are the steps we should follow. So ACLS treatment algorithm, if you see, it's always an integrated approach. It's always a team approach where the role of an critical care nurse is very, very important. So first, how do we confirm the cardiac arrest? We see the different responses. Basically, if you know, we have to see only the three response: whether the patient is conscious, is responding or not, whether the patient is breathing or not, and whether patient is having pulse or not. So for patient response, you can call the patient for just a second. Open the airway, check for the normal breathing, and for circulation, we see at the carotids, and for respiration, we see the respiratory rate if the chest movement is present or not. So please note that there might be some agonal breathing also, which is not normal breathing. So as soon as cardiac arrest is confirmed, you call the resuscitation team, that you activate the code blue and immediately start the CPR. If you have nearby, if you have the defibrillator there at site, immediately attach the defibrillator electrodes and monitor the patient. There should be minimum interruptions in between the cycles. So the chest compression, if we go, it is 30:2, and the compressions has to be of real high quality with minimum interruptions. So the compressions, it should be the center of the chest with a depth of 5 to 6 centimeter and at a rate of 100 to 120 compressions per minute. So average it is, in every second we have to have 2 compressions, and this compressions should continue once the airway is secured. Like, it should not break in between, and it should be continued for every 2 minutes, and then roles should be switched. If we have a 2-person there, then you switch the CPR provider from after every 2 minutes. So this is the chain. This is the cycle with minimum interruptions. Just a graphical representation. You start the CPR, you pause, you assess rhythm, which should be done within 10 seconds. By assessing the rhythm, we see whether the rhythm is shockable or non-shockable. Why it is important? Because shockable rhythms, you should immediately defibrillate as soon as you get the defibrillator or the AED there at the site. So there are 4 cardiac arrest rhythms, as we all know. Those are VF, that is ventricular fibrillation, pulseless, VT. These 2 are the shockable rhythms, and the non-shockable rhythms are the asystole and pulseless electrical activity. So this is VF. If you see in the ECG, this is the VF. ECG, which is bizarre, which is irregular. There is no QRS. The frequency is random. There is difference. Amplitude is random. There is no coordination of the electrical activity, and it's very fine. There is no pulse. This is VT, which is a monomorphic broad complex. The rate is rapid. There is a constant QRS morphology. There can be also polymorphic VT also. Important is if VT, sometimes VT are present. VT is there with pulse palpable. So in those patients, the treatment, the management is different. It's not a cardiac arrest. Cardiac arrest is VT without pulse. Is that clear? Okay. So again, you give the CPR, you're giving the cardiac compressions, you assess the rhythm, you decide or you see that those are shockable rhythms, then you get your defibrillator ready by still continuing the CPR. You charge the CPR, you keep the charge ready, and then you defibrillate once you are ready to defibrillate there and there by interrupting in between the compressions also. Immediately after delivery of the shock, you start the CPR again without assessing, without immediately after the shock, we start with CPR for 2 minutes. So this is the way by minimizing interruptions, you continue with the chest compressions. Now, defibrillation energies, it vary with manufacturer. We check whatever is the local equipment, whatever it is. If unsure, deliver the highest available energy. Usually in these new defibrillators, we have up till 360 joules, 200 joules in biphasic is enough. But if you are not sure about the equipment, if you do not know, whatever is the maximum energy you can, the defibrillator can deliver, you deliver that. So this is the way you place your electrodes. If you have seen a defibrillator in your units, you must have seen there are two paddles. The two paddles are, one it's labeled as apex, one is labeled as sternum. You lubricate the paddles, you apply lots of jelly on it, you place the apex at the apical part and the sternum at the position as it's shown here in the figure, and then you charge it. Before placing, charge it there when you are up, and then here you just clear the area and you just shock the patient by telling clear, everyone clear, and you shock. Now, then immediately after the CPR, as we have seen in the previous cycle, again after the shock, you continue the CPR for 2 minutes. Then you assess the patient again. If VF or VT persists, we deliver the second shock. So the cycle is same. Then again, we give CPR for 2 minutes. After 2 minutes, we assess the patient again and then deliver the third shock. Now, this it is said according to the ALS guideline that the second and the subsequent shocks, it has to be the same. It has to be at least the highest joules what we are giving. It may be till 360 in monophasic and 200 in biphasic. After the third shock, we might, if still the VF or the VT persists, then comes the role of amiodarone. We give amiodarone with a bolus of 300 milligram IV after the third shock during the CPR. Adrenaline, it's been given as the BLS guideline says, every 3 minutes, 3 to 5 minutes, we give adrenaline. And for the amiodarone, we say after the delivery of the third shock, the amiodarone should be given. So this completes with the management of shockable rhythms. Now for the non-shockable, that is the pulseless electrical activity and asystole. So again, same, you assess the rhythm when you're after the CPR, you make 2 minutes of CPR when you're assessing the rhythm. When you see it's non-shockable, for example, if it's asystole, where you get a flat line, so where the QRS is, the ventricular activity is not present, the atrial activity is not present, it's giving adrenaline every 3 to 5 minutes and continuing with the CPR. So this is PEA, where you may see even a normal ECG, or you may see a bizarre ECG without any output. There is no pulse. That is called a pulseless electrical activity, which is a non-shockable rhythm. So here also you continue with the CPR, and adrenaline may be given every 3 to 5 minutes as per our guidelines. So during CPR, you have to ensure that CPR, the compressions are of real high quality, that the rate should be adequate. It should not be too slow. It should not be too very fast. That's why, according to the American Heart Association, they have come up to a rate of 100 to 120. The depth has to be adequate. That is, it should be 3 to 5 centimeter of depth, or they say 1/3 of the chest, AP diameter of the chest. There has to be a complete recoil. That is very, very important. Then you plan your actions before you interrupt any CPR. Oxygen should be given. Consider advanced airway and capnography during in ICU setting. In a hospital setting, you may go, if you're given an advanced airway, you can attach your EtCO2 to confirm or to monitor the quality of your compressions. Then there should be continuous chest compressions when the advanced airway is in place. As we say, if the advanced airway is not placed, we give compressions by of 30:2. But in advanced airway, when it's in situ, you continue the compressions and the breath is given around 6 to 8 every minute. So that is not in a coordinated. The breaths, the airway person will be giving on breaths around 6 to 8 in a minute, and the compressions will go on at a rate of 100 to 120. Then vascular access has to be given. Preferable is intravenous. If intravenous is not available, you may go for intraosseous. Adrenaline every 3 to 5 minutes, 1 milligram of adrenaline. So this is the only drug which is used in ACLS. And correct the reversible causes. So what are those reversible causes? We'll see in a subsequent slides. So now, you see airway and ventilation. You can secure the airway by any of the airway devices. Any supraglottic airway device, maybe the LMA or the iGel, even the combi tube can be used if it's available. And tracheal tube, if you have an expert there, maybe they can intubate the patient, but intubation should be done by a trained personnel so that we do not have to repeat, we do not attempt, we do not cause injury, or we do not delay it. So once the airway is secure, do not interrupt the chest compressions for ventilations. Avoid hyperventilation. That's what we said. And you should always monitor the EtCO2. Vascular access, peripheral versus central veins. So during CPR, there is no point, or there is no role of developing or having a central access, because it's more time consuming. So always it's preferred for a peripheral. If at all peripheral access is not peripheral access is not available, you may go for intraosseous route as well. So these are the reversible causes what we have been discussing. So there are 5 H's and 5 T's. So what are those 5 H's? 5 H's is one: hypoxia, hypo or hyperkalemia, hypovolemia, and hypothermia. So we'll be discussing in a subsequent slides. Then 5 T's are tamponade, that is a cardiac tamponade, tension pneumothorax, thrombosis, it may be pulmonary thrombosis or cardiac thrombosis, and toxins. So hypoxia, and to treat hypoxia, we have to ensure that the airway is patent. Even if not necessarily you have to go for an advanced airway, even if you can ventilate the patient by bag and mask, or you can just have an airway patent and you can ventilate by giving him 2 breaths through just mask from your mouth. That itself is enough. If Possible in ACLS, what we say, if possible, wherever in a hospital setting, give high flow supplemental oxygen, avoid hyperventilation. That is very, very important. Hypovolemia, if there's any history of hypo, if there's shock, if there's trauma, if there's any bleed, if there's any severe vomiting, any loss, so from the history, you may get to know. Examination, like if there's any internal hemorrhage or external hemorrhage. Post-operation, check for the drains. If there is sudden collection of blood in those surgical drains. So treatment is you should control the hemorrhage, and if hypovolemia is suspected, give IV fluids. Then hypo or and other metabolic disorders, near patient testing for the potassium and glucose. Immediately you maximum of the ICUs we have ABGs there. You may immediately go for a ABG testing as soon as after resuscitation. And you also have to know from the history, that is very, very important. What was the patient? What was, so those patients during the course we can think about the causes, those reversible causes of cardiac arrest. So we know for treating hyperkalemia, we have used calcium chloride, insulin, dextrose. We also go for nebulizations by the Asthalin or Duolin. Then hypokalemia, we give supplements. For hypomagnesemia, we give potassium. For hypokalemia, we give potassium supplements or magnesium supplements as per the requirements. Then hypothermia in this tropical countries is rare, but yes, during surgery, especially in cardiopulmonary bypass surgeries, this hypothermia is seen quite often. So we treat with active rewarming techniques. We use blankets, warming blankets, use warm salines, warm fluids. Then this finishes up the 5 H's. Now we see the 5 T's. Tension pneumothorax. We have to know the suspicion if patient was being for any procedure like central line or any other procedure of the chest which are risk factors for pneumothorax. So we have to have a strong clinical suspicion that yes, that patient might have a tension pneumothorax and this might be the cause of the cardiac arrest. So for this, we immediately the treatment is needle decompression or thoracostomy. So the clinical signs, immediate at bedside. Do not wait for the X-ray to confirm the pneumothorax. Clinically, we may detect pneumothorax by decreased breath sounds. We get hyperresonant percussion note, and there will be a significant tracheal deviation. Tamponade, it's difficult to diagnose without echo, but at bedside, if there is a high suspicion again for tamponade, you may think and just put your ultrasound probe and check. So to treat, we need to decompress. We need to do needle pericardiocentesis or resuscitative thoracotomy. So we have to immediately involve the cardiologist or the cardiothoracic surgeons. Toxins, yes, rare unless evidence of deliberate overdose. If the patient have come with poisoning, with deliberate overdose, with suicidal, okay, then you have to review the drug chart, what are the toxins or what are the poisons that have taken. Thrombosis, as we have discussed, as we have mentioned, it may be either pulmonary thrombosis and cardiac coronary thrombosis as well. So we may consider for fibrillation therapy, or we shift the patient to immediate to the cath lab. Ultrasound has been proven and is very, very helpful during this scenario to identify the reversible causes. Also, this is very, very important to decide on whether this patient, is it important to continue with CPR or not. You can obtain the images during the rhythm checks. That would help us that we do not have to interrupt the CPR in between. So if we see the flow chart, again, this is nothing but same. Sorry. Yeah. So adult cardiac arrest algorithm is now, if we can summarize that, first confirm the cardiac arrest, confirm immediately. If we go for the chain of survival, activate the emergency response team and start compressions immediately. We give oxygen and attach the monitor or the defibrillator and check the rhythm only after 2 minutes of continuous CPR. If it's a shockable rhythm, we go for immediate defibrillation in spite where at what stage of compressions we are. And then if the rhythm after 2 minutes, after the shock, immediately resume the CPR for 2 minutes, then again check the rhythm. If it's still shockable, go for the second, or still shockable, go for the third, and after the third shock, you may go for amiodarone. And think also about the treatable causes. If the patient goes into non-shockable or there are no signs of return of spontaneous circulation, then you go for the, if there are still the non-shockable, then you go for CPR and adrenaline every 3 to 5 minutes. So when do we stop the CPR? If we see there are no signs of return of spontaneous circulation, and we can also confirm by the ultrasound as well. Or if a post-cardiac arrest team have come and then you shift the patient to the unit, to the center. So at least this chart, or this flow chart, you should all have in your unit for your all your juniors, your seniors to know what to be done and what not to be done. So here during COVID, we should also know during COVID time what are the, it's almost the same, but these are the do's and don'ts which is little bit changed. So during COVID, you should know that we have to limitize the personnel who are there and consider resuscitation appropriately. But so maybe with only 3 people there, we can have this whole CPR, the whole chain of survival being managed. Again, here we should prioritize intubation, because if we are doing bag and mask for long, it might be a risk to the others for the getting infected. So pause the compressions for intubation, and if intubation delayed, consider any other supraglottic device or bag and mask with filter, because we have to prevent those aerosol dispersal during the COVID pandemic. Now, if after the CPR, the patient have returned the spontaneous circulation, then we go for immediate post-cardiac arrest treatment. So how do we go for that? First is immediately the ABCD approach. We check the airway if the patient is not intubated, or even if it's intubated, what is the airway, if it's suction is needed, if there is secretions, and check for the breathing pattern. If required, patient might be needing ventilatory support. The circulation, what is the hemodynamics, if needed, maybe he might be needing more fluid resuscitation or vasopressors, and then other disability and this approach. Then controlled oxygenation, controlled oxygenation and ventilation, attach the 12 lead ECG, treat the precipitating cause, then temperature control and therapeutic hypothermia is very, very important, because it has been proved if that the post arrest neurological disabilities are less. So this is the algorithm for the adult post cardiac rhythm. So you manage the airway, manage the hemodynamic parameters, and obtain the immediate cardiac intervention if required. Then after maintaining and after stabilizing the patient, we also see whether the patient is following command or not. If yes, patient is awake, then other critical management. If patient is still comatose, then this is the algorithm that you obtain the CT brains, you do a EEG and other critical care management. So, so this is the time we see what are the investigations to be done after the return of spontaneous circulation is attained. So immediately if we see, we have to do a TTM as soon as possible. HCT is also done, and then the EEG. So this, as I've already mentioned, the CPR is always a it's always a team. So we have to, the team should the roles in advance. So always, if you see, there is in hospital, there is always a team, a code blue team, where you know the roles, where you know who is, you identify the team leader. Importance of the non-technical staff is also there. It's always a very structured team where the communication has to be there. If all the members of the team are well trained and they know what to do, what not to do, then the whole program becomes a very smooth, without any chaos. But if there are lack of training, if there are lack of knowledge and what to do, we do not know, then it becomes a chaotic thing. As we see even in practical scenario, if the arrest is there in ICU, where all the staff are equally trained, it's always a non-chaotic program. But if you see in wards or in other places where the support is still without the training is lacking, or where they are not well exposed, then always any arrest, any cardiac arrest becomes a very chaotic scenario there. So to summarize, we should have a proper SCLS algorithm as per the American Heart Association. The importance of high quality chest compression should be given. We should know the treatment of shockable rhythms, and we should also know the treatment of non-shockable rhythms. The drugs during the cardiac arrest should be clear, and we should be very much clear about it, that what are the drugs used in cardiac arrest. We should know the 5 H's and the 5 T's, and as I've already said, it's always a teamwork. So this role of this resuscitation team should be there. Thank you.
Thank you, Dr. Reshu. It's my privilege to hear Dr. Reshu, and as always, it's a very nice presentation.
I don't know how to get to the. How will I? It is close to it. Okay. Okay. So, any questions?
Thanks, ma'am.
Very nice presentation, Dr. Reshu.
Oh, thank you.
You involved all the points, especially the COVID points. That is important because this is the COVID era, and we are facing day to day more and more CPRs of the COVID patients. And of course, there are few more points for the COVID patient, that you must inform all patients, all persons who are enrolled in CPR, that status of the patient should be informed, especially newcomer, because you are in ER and you don't know whether you know that patient is COVID patient or not. So status information should be on the regular basis, frequently. Second, intubation should be tried only by expert persons. If you are not confident enough that you will do intubation at once, don't attempt. Instead, you use a bag valve mask, as she told, and with HEPA filter, of course. And you may use LMAs. That's better approach if you cannot do intubate or you are not confident enough to intubate. And one more thing is that you have to stop the chest compression while intubation is going on, because that is to minimize the infection, COVID infection in such patients.